What we presented today was the clinical safety and efficacy of bioresorbable stents in patients who have threatened limb loss or severe claudication and have severe infrapopliteal arterial disease. There's a variety of different ways to treat the patient population, and what we looked at in a retrospective fashion at one center in North America was whether or not bioresorbable scaffolding when placed in one of these arteries actually improves the clinical symptoms of the patients and is safe to do. And our take-home message, which built upon the last year we presented the one-year data, which showed that 95% of patients had no problems at 1 year. No stent thrombosis, no need for repeat revascularization. They did very, very well. But the question is, what is the long-term results? And this year we presented the 2-year data, which showed that of the 31 patients we studied, 27 were free of any cardiovascular events. No other reasons for having revascularization, no death, no amputation, and importance of the safety element of this scaffold, no bleeding or stent thrombosis. Metal stents have been around for almost 30 years. Drug-eluting stents have been around for about 20 years. And the thought process is the metallic portion of a stent gives the scaffold strength and integrity to keep the vessel open. The drug, which is then imbued on a bioresorbable polymer, elutes that drug into the vessel to prevent neointimal hyperproliferation, to prevent the vessel from gumming up. However, over time, once the drug is gone, the polymer may still be there and the stent may still be in there. That piece of metal stays in there forever, and we don't know whether, one, there's a risk for late stent thrombosis with that metal, or two, having a piece of metal in an artery may inhibit vasomotor function distally. So it becomes very provocative and exciting to think that there's a stent that has the same type of scaffolding rigidity that can elute a drug, but where that metal, which could be a source of vasomotor dysfunction or late stent thrombosis, is completely gone after 6 to 9 months. So in the early days of angioplasty, it was just a balloon placed in a vessel. The balloon was inflated, it stretched out the artery, cracked the intima, and kept the artery open for about half of patients up to 6 months. But then the vessel would recoil. So the initial stents were placed to prevent that immediate recoil. That once we've dilated the vessel, let's scaffold it open so it doesn't recoil immediately. However, over time, the immediate recoil threat goes away, and then you have just the progression of natural atherosclerosis in our patients. Our patients don't stop eating Big Macs as soon as they get a stent in. So a lot of those risk factors do exist. And the stent helps keep that artery open, and it's a subject of a lot of controversy. The stent may be needed from anywhere between 6 months and 12 months. It's very clear after 12 months, it's unlikely for the vessel to mechanically recoil on itself. If there is lumen loss, it is from neoatherosclerosis or restenosis. And so the idea that there's a lot of data suggesting that the need to prevent recoil even late, it goes away after 6 to 9 months, which makes an idea of having a stent that dissolves after 6 to 9 months particularly attractive. So when we learn from primary angioplasty, if we have a vessel that's 3 millimeters in diameter, if we want to have the best likelihood of procedural success, we want to dilate with a 3 millimeter balloon. We want to dilate at a 1-to-1 ratio. However, once we start dilating at a 1-to-1 ratio, there is a slightly higher chance of causing a dissection or perforation, which is why in the coronaries, plain old balloon angioplasty has been cast to the wayside, and we often put stents to preserve the integrity of the vessel. In the periphery, there is renewed exploration and interest in drug-coated balloons to help treat infrapopliteal disease. However, as we're seeing today and at conferences in the past, there's a lot of controversy with the current drug that's used, paclitaxel. As you know, paclitaxel is not used in any more coronary devices. It is the inferior agent compared to everolimus, zolidrolimus, or even sirolimus, but yet we're using paclitaxel below the knee. And now there's been a signal for increased cardiac and non-cardiac mortality with the use of paclitaxel below the knee. So in my opinion, plain old balloon angioplasty can be associated with structural defects, tearing the vessel, dissecting the vessel, and using a drug that may increase mortality, I think gives me pause for concern, especially if there's a stent that will help scaffold the vessel and doesn't have the same type of signal for increased mortality.